So, this is Dr. Moses. I'm going to try to keep this pretty short. We're going to talk about liver transplant, kidney trauma, and I've got it on here as CVVH or CRRT. They are interchangeable, and we'll talk about that in a second. But so, just three different topics here we're going to go into, and I do want to say, kind of with the transplant, we do talk about rejection, but we'll go into that. So, first things first, let's talk about the need for a liver transplant. And I know, Adult Health 2, we did a lot of talking about cirrhosis and hepatitis, and, Hep C usually then leads to cirrhosis, and cirrhosis is the most common cause of liver failure that leads to the need for transplant. Other causes can be chronic Hep B, C, bile duct disease, autoimmune liver disease, alcoholic liver disease, fatty liver disease, liver cancer. So, there are other reasons that we can see somebody need a liver transplant, but those are our main causes. So, there are certain things we have to think about when it comes to evaluating who can be a candidate for a liver transplant. They have to do an extensive physiologic and psychological assessment and evaluation by their healthcare provider and transplant coordinators, and then they need to make sure that their treatment, all other treatment options have been explored before they become a candidate for liver transplant. So people that maybe are not candidates are those with like severe cardiovascular disease, severe respiratory disease, those with metastatic tumors, and then the inability to follow instructions regarding drug therapy or self-management. So they do take a lot of that into consideration. Personally, so my father-in-law back in, I think it was 2023, he actually had liver cancer and had to get a liver transplant. And it was very fascinating actually learning about being able to be a candidate for a liver transplant with liver cancer, because there's a very narrow window and it has to be caught very early. Tumors have to be very small just because the liver is so regenerative. If those tumors are just, over a certain centimeter in size, they won't do the liver transplant for those individuals. So it is very interesting that they, have very extensive criteria that they look at. I will also say that criteria can vary across transplant centers and change as surgical techniques advance. Where you live can dictate, what surgery centers or transplant centers will accept and not accept. So I do want to just touch, and I don't have the answers to this, but there are some ethical considerations that have surfaced as liver transplantation has become more common and the need for donors has increased. So some of the more commonly seen issues that exist right now is ensuring that living donors are provided complete information about risks associated with transplant surgeries and informed consent, increased use of Hep C infected livers for transplantation since there is therapy more available. So that is something that they can use a liver that does have Hep C because they do have the direct acting antiviral therapy to treat Hep C. So that is something to kind of keep in mind. There might be people who would not want to have a liver that was infected with Hep C. So it just is something to kind of keep in mind. There are more men than women that receive liver transplants despite using the MELD, which stands for the Model for End-Stage Liver Disease score, to determine the urgency for the need of transplant. I do not have an answer as to why or what the case may be. And then, for some reason, fewer liver transplants are performed for patients from Black and Hispanic populations when compared to the white population. So it's very interesting. So I think as nurses, we really need to just make sure we advocate for all of our patients, that they have an urgent need for a liver transplant, regardless of the race, ethnicity, or gender. We need to really kind of advocate for them and help make sure they've got the knowledge that they need. When it comes to a liver transplant, there are the abilities to either have a deceased donor or a living donor. Just kind of like with the kidney, you've got two kidneys, so you can, if you're a match with somebody can donate their kidney. Well, with your liver, it regenerates, and so you can have living donors. That being said, I know in this area, and again, this goes back to my father-in-law, because of course, my husband and his brother were both, one of the first questions they asked was, can we be tested to see if we would be a match to donate you part of our liver? And my mother-in-law and father-in-law had said that in this area, they actually do not take living donors because they have enough deceased donor livers available in this area that they do not need to utilize living donors for livers in this area. So again, you might go somewhere else to see something different. But typically we see livers that are from trauma victims who do not have liver damage. And then they use, like I said, they use what's called the MELD scoring. And I thought this was very interesting as well. So MELD scoring, it's kind of, I think in our brain we think, oh, I got put on the transplant list, I'm number 27. So then, person who's number 1 on the list gets the next organ, and then now I've moved up to 26, and so forth and so on. But when it comes to MELD scoring, that's not how it works. It's a dynamic scoring. So, like with my father-in-law, his MELD score was pretty low initially because like his age, the staging of his liver cancer, his liver function panel, all of these things, the size of the tumor, so all of that was taken into consideration. His numbers were lower. Then they did a type of radiation, and then that instantly made his score go much higher. So those scores change, and so when your score becomes higher, you move higher on the list. And so it's a dynamic scale on who gets the next liver. So when it comes to doing a liver transplant and a living donor, the organ will grow to meet the demands of the body. We monitor those patients in the ICU post-transplant, and then we will talk. Our most common complications include acute graft rejection, vascular or biliary rejection, and then infection. So, now that we've got different antibiotics and we understand we're doing a lot better, success rates have greatly improved with time, but these are things to keep in mind. Another fun fact that I learned with my father-in-law getting a liver is you get the call. You have to be there within 24 hours, but 2 people are called. Because say the first person gets there and say you're number 1, so they're going to call number 1 and number 2 who are on the list. And both of them go through all of the testing to be prepared for surgery, say at 8 a.m. the next morning. And so, like in the instance of my father-in-law in 2023, whenever he had his first call, we got up there, they did all of the testing, and at midnight, his COVID test came back positive. So he got excluded, and he did not get that liver, and he had to go back home. And so then the guy who was number 2 on the list actually got the liver the next morning. He had to then do testing. He had to recover from COVID, and so he was taken off the list until he had a negative COVID test, and then he was put back on the transplant list. And then a couple of weeks later, got a phone call again, was number 1 on that list, and then he did receive that liver the second time. So it was very interesting. Nobody really thinks about what happens, or that they call in multiple people to potentially get this organ, but maybe the second person doesn't get it. And I think there's a lot of psychosocial considerations to keep in mind. Like, think about being number 2. You show up, you're number 2 on the list, so you of course want this other person to be able to get the organ that they need. But if they get it, that means I don't, and so I have to keep waiting. And depending on the severity of their disease, that's a big deal to kind of keep in mind. All right, so postoperative complications here, we're talking acute graft rejection is our most common. So things that we would be looking for with acute graft rejection. So this is usually going to occur, 7 to 14 days post-op, but we're looking for an increased heart rate, fever, right upper quadrant or flank pain, diminished bile drainage or change in bile color. Maybe they have increased jaundice. We might start seeing changes in their labs with an increase in serum bilirubin. Our ALT, AST will start to increase, alk phos will increase, we'll start to see an increase in our PTINR. So we start to see those labs trending up. And so the best thing you can do to try to prevent that is then going to be prophylactically with immunosuppressant agents such as prednisone. There's a medication you see used a lot called tacrolimus. A lot of people just call it Tacro for short, or cyclosporin. And so then it's just really important that we get early diagnosis if we start to see acute graft rejection to treat with more potent anti-rejection drugs if needed. Infection, so this would be any time during the recovery. We're looking for fever, excessive or foul smelling drainage. Do we get urine, wound, or bile that starts to smell foul? Other indicators depend on location and type of infection. So again, things that we would be looking for postoperatively. Hepatic complications, so we would be looking for like bile leak or abscess formation or hepatic thrombosis. So we could see a decrease in bile drainage, an increase in right upper quadrant pain with distension and guarding, nausea, vomiting, increased jaundice. Maybe we start to see some of those clay-colored stools. And then again, lab work-wise, we might see our serum bilirubin and like our ALT starting to increase as well. And then an acute kidney injury can also be a postoperative complication we look at because it can be caused by hypotension, antibiotics, cyclosporin, acute liver failure, or hypothermia. They can all cause an acute kidney injury. Early indications we're looking for changes in urinary output, increased blood, like our increased BUN and creatinine, electrolyte imbalances, so things that we'd be looking for. So we need to be cautious. If we know we have a patient on a nephrotoxic drug, we need to be looking for that. We want to try to prevent hypotension because if they're hypotensive, I can have a pre-renal kidney injury due to the hypovolemia to the kidneys. So I just need to be looking for that. So when it comes to these individuals, we are obviously managing them in a critical care unit, doing very frequent assessments for vitals, hemodynamics, respiratory status, neurological changes. We're looking, they're going to have JP drains. We're looking at their bile output, color amount report, any changes in drainage, changes in color, changes in odor, anything like that. Central lines we're going to have with these individuals for fluids, immunosuppressants, antibiotics. We know when we have a central line, there's a risk of infection with that as well. Art lines for continuous blood pressure monitoring and frequent labs. And then they may require, depending on the severity of how sick that person was prior to having it. So like with my father-in-law, he was really not that sick at all whenever he went into the surgery. So he was only in the ICU pretty much for a day and then was back up on the floor. Whereas if somebody was in like end-stage cirrhosis and, very ill, they may require more. So they may require mechanical ventilation in that early postoperative period. They may require dialysis if they suffered acute kidney injury. So we have to look at that and with that monitoring. All right, so what do we do? What are we looking for and what are our considerations? So again, to prevent infection, I think this should be very self-explanatory at this time. I think good hand hygiene, getting cultures, tubes, lines, drains, anything like that. Early removal of invasive lines when medically appropriate. Broad spectrum antibiotics initially, and then if there's any type of infection, that's where those cultures come into play so we can give them on a more specific antibiotic if needed. Safety alerts. So again, looking for fever, increased white count, any foul drainage, pain, distension, rigidity, any neurological changes which could be related to encephalopathy, bleeding, petechiae, or oozing at art lines. Again, if I got impaired liver function, then that's where I can see an increase in that PTINR. So then that prolonged prothrombin can increase my bleeding. And then if a rejection occurs, that's where I was saying that aggressive immunosuppressive treatment will happen. And if that is not successful, then you can lead to rapid liver failure, and we have to do an emergency retransplantation. So it's obviously a very big deal if we go into an acute graft rejection. This is kind of reiterating what we said earlier. What are we looking for? Signs and symptoms of pain, tachycardia, fever, right upper quadrant or flank pain, decreased bile, jaundice, elevation in our liver enzymes, PTINR, and then if we start to see peritonitis again, we're looking for that swelling, rigidity, pain, and the abdominal cavity. We talked about MODS earlier in the semester, so multi-organ dysfunction or can happen. So we really have to be careful and look for that. So we start to see an increase in ammonia levels, confusion, slurred speech. So looking for MODS is very important. Only thing we can do if we go into rejection is a retransplantation. Big thing with them, obviously, is we're looking and they are going to be on immunosuppressive therapy for life. So that's something we'll kind of talk about. But just to kind of keep that in mind. Something I didn't say about with infections, because I did talk about like early we're looking for, pneumonia, flu, UTI, those types of infections can happen. Then we also see more opportunistic infections happen after the first month, which could be like your cyclometavirus, bacterial, parasitic infections can happen. And then we can also see latent infections such as TB, HSV may reactivate. So we're doing broad spectrum before and after, and then again switching if we start to develop an infection. So like I said, they will be on long-term use with immunosuppressive drugs. So teach about side effects, hypertension, nephrotoxicity, risk of infection, again, avoiding large crowds, all of the things we've talked about when it comes to taking immunosuppressive therapy. I pretty much think that's it that I really want to talk about, like liver transplant and transplant rejection. And, we're talking about liver, but when we start talking like signs and symptoms of rejection, those are pretty common concepts that go with any type of organ transplant. So I do want to move now into kidney trauma. And I do want to be very clear that kidney trauma and CRRT or CVVH, they do not necessarily go together. It's not because I've had kidney trauma is not really the only reason I would use CRRT. I don't want that to be confusing. It's just because this is in critical care what we talk about. These were the topics assigned. It makes sense to talk about them in the same day. That does not mean you have to have the kidney trauma in order to have the need for CRRT. Okay, so kidney trauma is trauma to one or both kidneys. It may occur with either penetrating wounds or blunt injuries to the back, flank, or abdomen. Another cause of a kidney trauma is usually urologic procedures. Blunt trauma accounts for most kidney injuries. And then like traumatic kidney injuries, they are graded 1 through 5. Okay, so when we think about that, grade 1 is low-grade injury in the form of like kidney bruising, minor contusion, hematoma, whereas grade 5 represents the most severe variety of injury to the kidney, which is shattering of the kidney, tearing of its blood supplies. So, there is a variance in how they are graded. Common causes, MVAs, falls, sport injuries, any adult can be affected. And so really the biggest thing we can try to do is think about how do we prevent it. Wear seatbelts, use like protective gear, helmets when riding bicycles and motorcycles, wear protective clothing when participating in contact sports. So very importantly, if you're playing tackle football, you've got your gear on. If you've only got one kidney for some reason, then it's probably pretty important we should maybe just avoid contact sports and high-risk activities if you only have one, okay? So we really need to just kind of keep that in mind when it comes to prevention and what we're doing for these individuals. So what are we looking for? Obviously the history, mechanism of injury. Were they in an MBA? Were they on a motorcycle? Did they get hit during a football game? Did they have a urologic procedure done? So those are things we're looking at. We do also have to keep in mind, did they get a minor contusion, but do they have a history of hypertension? Do they have AFib and they take a blood thinner? So, these are things we also need to keep in mind with the history that could impact what we look at when it comes to a kidney trauma. Symptoms are going to be flank or abdominal pain, hematuria, bruising or swelling in the flank. The symptoms are going to be flank or abdominal pain, hematuria, bruising or swelling in the flank, and then blood at the urethral meatus or something we would be looking for. When it comes to our physical assessment, we are looking at vital signs for shock, inspecting the abdomen, chest, flank, trauma signs, and then diagnostically we're looking at their UA. We're looking for, is there blood in their urine? If this is a trauma, what is my hemoglobin levels? CT, ultrasound, evaluating the vessel integrity, hematomas, urinary tract patency, and then labs we might see with a low H&H with blood loss. CT is going to be the gold standard for defining the injury grade and guiding treatment decisions whenever it comes to our diagnostics. So our non-surgical management is going to be IV fluids, blood products for volume replacement, monitor for shock. Obviously if this is an MBA or some type of trauma, we need to be watching them very closely, looking for blood loss, signs and symptoms of hypovolemia shock. Very important we're getting hourly output for our urinary to see, how much urine am I producing. Most kidney injuries heal without open surgery, so a lot of times we are just focusing on stabilizing our circulation, preserving the renal function, and preventing any further damage. Another important thing on this is do not insert a urinary catheter if urethral bleeding is present, just because if there is trauma in there and then we try to insert a catheter, could we make that trauma much worse? So it is very important that we do not insert anything until they have been seen by urology, scans have been done, or anything like that to make sure we don't do more damage to that individual. Interventional IR can do things depending on what has happened for that individual to try to repair or fix any trauma that's happened. Surgical management, again, this is going to be for ongoing bleeding or regular abdominal injury. Our goal is going to repair kidney and restore function. And then grade 5 injuries may require we do a nephrectomy or just remove the kidney. If it's lost, I'll supply. What we're going to teach is to watch for infection, urine leakage, delayed bleeding, report any signs of hematuria, fever, pain, chills, cloudy foul urine, and then we would be looking for post-traumatic hypertension, because if there's been renal perfusion changes, could this cause backup of fluid, which could then lead to that hypertension. So it's just, the kidney's trying to figure out their new normal, so we do need to look for that. So that's really all I want to hit on kidney trauma. So our continuous renal replacement therapy, another, like I said, and I did put this on the main slide, is we also will see the most commonly used CRRT is what we call is a continuous veno-venous hemofiltration and continuous veno-venous hemodialysis. So that's where that CVVH comes into play, okay? But continuous renal replacement therapy, or CRRT, it is not necessarily just because of kidney trauma. So we are seeing this a lot of times. This is an ICU only. This is, when we talk about with hemodialysis and health too, how it is a pretty rapid change. And your body has to be able to handle that quick change to be able to balance out and meet that homeostasis. But if somebody is extremely ill and very critically ill, their body cannot handle that rapid change that comes with normal hemodialysis, okay? That being said, if they are critically ill, they are also not a candidate for peritoneal dialysis, which doesn't have that massive shift like hemo. But, placing a catheter, letting it heal, that passive process takes a lot of time. And so if somebody is very critically ill, they're not a candidate for peritoneal dialysis, but they also might not be able to hemodynamically handle the massive changes with your normal hemo. So CRRT is this option where it is a continuous cycling that is chosen over intermittent. So it allows for a more gentle shift in restoring the acid-base balance, the electrolyte balance in the body, okay? So it doesn't have these changes of blood pressure that occur with your conventional hemo. So it is over 24 hours, and it is a very, very labor-intensive process. If they need this, mortality can be as high as 50%. This is not, this is a very, very high acuity patient. So this is something individuals have to be extensively trained in order to be able to administer. So not just anybody. You can work in ICU, but not even all ICU nurses are trained in CRRT. So this is something, if you do choose to go the ICU route, you may get trained in doing CRRT, but that does not mean everybody is going to do it, and it does not mean that I expect you to know how to do it in this course. I truly just want you to kind of understand what it is, why we use it, and the importance on how closely we have to monitor these individuals, because any interruption can be fatal for them. So it's just a very labor-intensive process and takes a lot of training, but it is something that we offer for individuals who are in the ICU setting. And that is it, guys.